Hamilton Health Sciences, we're a bit of a perfect storm, I think, is happening. Where we're challenged because we're very lean, we have limited resources, yet we have great demands for professionals to be here and to fill. So we need leaders to be supportive of the concept of recruitment that is not only going to happen within our community, but broader. And what will that mean in terms of changing their practice as leaders? And I think it's significant.
At the Scarborough Hospital, we place a high value on IEHPs. So we not only work with bridging programs, we also make sure that our managers recognize that individuals are IEHPs and may need a higher level of onboarding or perhaps a longer period of orientation, just so that they can integrate themselves and they can familiarize themselves with practices, equipment, software, structure that they are not familiar with.
We have to talk about the people. How do you fit into this department? You know, when do we have lunch? where do we hang our coats? How do we talk to each other? That's a different kind of leadership that we're asking.
For IEHPs, they are walking into an environment where they are not familiar with. They're not familiar with the equipment, the software, some of the practices, as well as legislation. Okay? So it's important on the IEHP side, to make sure that they have equipped themselves with the knowledge, but it's also important on the staff side, the existing structure, to be able to welcome them and support them and integrate them into the organization by providing services that support them.
It's basic civility, but to a certain extent we've lost some of that basic civility. So this is a great opportunity, I think, to rebuild integration the way it should be.
It is much easier for an organization with an embedded diversity program to be able to accept and integrate IEHPs in that kind of a culture than it is for an organization without such a high degree of focus.
One of our deliverables is to ensure that we're planning and delivering training and education, providing resources to our staff to ensure not only is there inclusive and respectful service delivery to our patients, but that there is a respectful and inclusive work environment for our staff as well.
Our training is really focused on working in a diverse environment, and we've made that training mandatory for our leaders and for our staff. It's a very important part of our culture.
The organization felt that they were trying to figure out how to integrate their internationally educated professionals, because it's not just the physicians. We have nurses, we have social workers, we have physiotherapists, we have pharmacists, we have so many other non-professional healthcare staff members who are coming as well and working in our organizations.
What we do is make sure that we cover the values of our organization, and two of those 5 values, one of them is respect and the other one is diversity. Those 2 values are key in this particular training. There's a lot of self-assessment that's done, self-reflection. There's a lot of discussion that goes on to ensure that we're not only providing the training, but there's some significant change that comes about. There's e-learning that we have, tools and resources that we've developed in-house. For example, providing care and working with the Sikh population, or the Hindu population, or Jehovah's Witnesses, etc., etc. The senior leadership team want to hear updates on health equity and inclusion. How are we doing in the organization? At one of these formal updates, I pointed out that there have been some challenges in working in teams. So the senior leadership team recommended that we work with our managers, with the directors of those particular areas or that particular unit, and plan a training that was specific, that would meet the needs of that particular team. And that's what we did. We do have quarterly health equity forums. It gives staff, employees, physicians, volunteers to drop in and learn about different topics and themes that we've become aware of, that has been identified as a need. Anything that really impacts staff and employees and patients in our diverse working environments. We do put together when we deliver our training, pre-assessments, post-assessments, evaluations, track what kind of behaviors have changed, if any. And that really gives us a good idea whether the training has been effective or not.
We really, at the Scarborough Hospital, wanted to look at staff education related to diversity in different ways. Really, at the end of the day, mandatory staff education that talks about compliance and legislation really is not a compelling enough reason for people to change behaviors and attitudes.
All our staff have been through diversity training over the past 2 years, and it's part of our ongoing training and approach. So every year we have a diversity focus under our learning and development needs for our staff. There is a classroom session just on what diversity means, on what inclusion means, on what equity means.
Since 2011, we have ran a series called Embracing Diversity Through Personal Journeys. We've invited our staff and our community and patients as well to attend these sessions, and our staff have also participated in sharing their stories. And what really has been amazing is that staff, other of their colleagues that listen to their story, really recognize and learn from their experiences some of the challenges and obstacles that they might not have recognized or realized that their colleague has faced. It's a powerful tool. And it's one that we have found so much of our staff have been so engaged in, and we've had great participation and engagement around it. We have made mandatory for all of our leaders to do bias-aware education. And we found it was really important that we moved beyond legislation and compliance to really being able to spend some time better understanding my own biases, because we all have biases, but it's about being aware of those biases and being able to mitigate that before it becomes discriminatory practices.
Last year we introduced a certificate program for our staff. You're constantly getting new staff in the door, so it's important to make sure that on a constant basis you're providing that training and refreshing that on an annual basis.
We always think about what does the system need, what does the professionals need, but what about the internationally educated professionals themselves? What do they want? We had an organizational development expert, and she and I collaborated and designed workshops focusing on communication and focusing on understanding the feedback. And the difference about that workshop was because we were not just talking about communication and feedback in a Canadian context, but what is the impact of culture on it?
What are those strategies that are important in a Canadian culture, or at the same time, a Sunnybrook culture?
We were surprised by how much interest there was. Like, we got people who were working in Sunnybrook for 13 years, 15 years, came to attend our workshops. And since then, now we have consolidated them into 2 workshops, one on communication and one on feedback, and we were offering them twice a year. So this is our 5th year.
So these 2 programs are 3 hours in length, and they allow for those rich discussions and at the same time taking away some key tools on how to integrate.
And I think the workshops have gone beyond the boundaries of Sunnybrook, because 2 of the training programs at University of Toronto, the hospitalist fellowship programs, one at Sunnybrook and one at Toronto General, now they send their IMG fellows to attend our workshops.
We do language communication for nurses advanced. It's a workplace communication specifically set up for the internationally educated nurses. Job shadowing, we get them to the 2nd general nursing orientation, which are usually for people who are hired at HHS. So they come in contact with people that they succeeded in their hiring, so they feel encouraged now. Because they will see among those people some of their colleagues, INs or ESLs. So that's a bonus for them, they understand. And also we have a career progression. In the career progression we do different lunch and learns. We have an office where we have an e-lounge where they come and they're able to access different skills, review their skills, different policies we have here at HHS. We develop a learning plan for them, that's another intervention. Also we do a job coaching mock interview, that's another thing that we do. And we have an networking program. It's called Nursing Nurturing Nurses. It's based on the American model it comes from the Medical Surgical Association. of nurses in the States. It's called N3, and we're trying to develop this one into an IN network. And what we prepare through this network are the clinical integrators, the informal mentors who are supporters of the IN ESL participants.
The program in particular has done a lot of work to understand how you are entitled to basic human rights here, and that you're allowed to ask for those things.
And after they're being hired, the most important thing, workplace integration and retention within the team community that they have, within the hospital as well. But taking it a step further is integrating in the community where they live as well.
Some of the education is not just to our IENs, it's to our staff group to say, how do you welcome someone who has some differences? Well, we try to reinforce mutual purpose. We try and reinforce mutual respect as key components.
Mentorship is really important, and so, and especially when you're a newcomer to Canada and a newcomer to the organization, where can they grow? What is the opportunity for professional development? What is the transfer or the change process? How does this organization work? What do I do when I'm in Canada? How do I deal with a colleague of mine who may not understand what I need to do or what I need to practice or how I need to dress or how I need to pray?
And this is where the role of the clinical integrator, the informal mentor, comes. We're moving right now in creating a much bigger sphere, like an IN network. The criteria for us is for them to be working at least for 1 year in Canada, so they have that work experience. And anybody can be a clinical integrator. They could be nurses, they could be managers, they could be clinical educators, and we have some of those.
Staff really are very much engaged in mentoring, and it really leads to an added bonus of really increasing staff engagement. And so it's a ripple effect that you might be actually trying to support the IHP through a mentoring program, but by way of the ripple, you're actually also supporting the engagement and the value of transferring that knowledge.
We have our senior leaders in particular who have come forward to be the mentors. And we have, for example, a women's group that has been formed, and they will interview our senior leaders so that others can learn from them.
I'm an educator and assistant professor of medicine at University of Toronto. I'm faculty, I'm there, and then we have senior IMG residents they and I are mentoring the junior IMG residents. I got another scholarly grant to study the effectiveness of the mentorship program. So there's a lot of research on mentor-mentee relationships and different models of mentoring. So one is the traditional dyad model. There's a mentor, there's a mentee. Then there is group mentoring. Like, group mentoring works well for those mentees who have similar needs. For example, the IMG mentorship program which I've designed, that's why it's working well, because we have similar needs from a group of residents. However, I think one thing important to understand is not one thing could be sufficient. So we may have a group mentoring or we may have a collaborative mentoring model, but we do need a dyad or an individual mentoring on top of it as well. It has to be confidential. It has to be open. You can be it has to be a good sharing of things as well. And the other important thing for mentoring is a person who is your boss cannot be your mentor. A person who has the authority to evaluate you should not be your mentor. So I think many organizations they confuse both of them, the role of coach and the role of mentor, or role of supervisor and role of mentor. Mentoring has to be separate from supervising or coaching. I think that's the one distinction needs to be made. And the other piece is it has to be a buy-in from a mentee that this is going to work for my benefit, for my professional growth. So I think that's another two things which are needed for a good mentor-mentee relationship.